Welcome to KMET 1490 AM ABC News Radio and the Southern California Business Report with Yvette Walker, a show dedicated to highlighting successful Southern California businesses and the people behind them.
Welcome and thank you for joining Southern California Business Report on ABC News and Talks, KMET 1490 AM, 98.1 FM, and KMET TV. I'm Yvette Walker, live blasting our signal from the center of Southern California, serving a population of over 25 million. Get us crystal clear and on demand by downloading the free live streaming app on Google Play and the Apple App Store. As always, a huge shout out to the team. Mitch, Bill, and Sean, I love you guys, and to our special advisory committee that can be found at www.scbrtalk.com/advisory committee. Click on the link and learn about the leaders doing the work. Speaking of leaders, I have a panel of leaders here today taking a deep dive into the ever-evolving landscape of healthcare in California. We will be starting with Mr. George Greene, who joined the Hospital Association of Southern California, HASC, as president and CEO in 2017. Since then, the association has added community outreach initiatives and led critical healthcare coordination across the region. In addition to leading local advocacy efforts for over 180 Southern California hospitals, Greene has guided new HASC initiatives, including Communities Lifting Communities, or CLC, a nonprofit charitable affiliate focused on advancing significant systems change through a collective impact model involving hospitals, health systems, and local healthcare stakeholders. CLC's Cherished Futures for Black Moms and Babies carries CLC's work into underserved Los Angeles County communities with a focus on birthing health. Under Greene's leadership, existing HASC affiliates and initiatives like the association's ReadyNet emergency communication systems, National Health Foundation, and endorsed business partner program have expanded and prospered. Since the outset of the pandemic, Greene has mobilized HASC to lead a coordinated response for the region as multiple hospitals and organizations continue to act together in response to COVID-19. Prior to taking HASC's reins, Greene led the Healthcare Association of Hawaii, a role he held since 2009. He previously worked for the American Hospital Association as regional executive for California, Washington, Oregon, Nevada, Alaska, and Hawaii. Before this assignment, he worked with Sharp Healthcare of San Diego as Director of Advocacy, Community, and Multicultural Affairs. Greene launched his professional career in Washington, D.C., where he was counseled to South Carolina Representative Bob Inglis, his hometown's congressional representative. He subsequently worked for the National Association of Home Builders and San Diego Mayor Susan Golden. Greene earned a Juris Doctorate degree from the University of Tennessee and a bachelor's from Clemson University in South Carolina. He resides in South Pasadena with his wife Stacy and children, Gabrielle, Keely Pono, and the newest addition, Grayson Miles. To my left is Mr. John T. Chapman. He is the president and chief executive officer at San Antonio Regional Hospital in Upland, California. Mr. Chapman joined the hospital in 2018 and is currently serving as the 7th president and CEO in the history of the hospital. San Antonio Regional Hospital has 363 beds, a staff of over 500 physicians, 2,000 employees, and 300 volunteers. The hospital offers advanced patient care throughout the Inland Empire. John also currently serves as the CEO chair for the Hospital Association of Southern California Inland Empire Region, as well as serving on the board of directors as second chair for the Inland Empire Economic Partnership. In his 5 years at the helm of San Antonio Regional Hospital, John has ushered a financial turnaround that has been seen the bond rating agencies improve the ratings of the hospital each year during a time when the hospital industry in general had a negative outlook. San Antonio has continued to grow their programs and staff, achieved numerous national awards, including the only hospital in our area with a 4-star Medicare ranking and top 50 cardiology hospital in the nation. San Antonio Regional Medical Group, with multiple sites to increase providers for our community, created a new ACGME residency program for internal medicine and family medicine, opened new urgent cares, and most recently purchased a 185,000 square foot building in Rancho Cucamonga to serve as a center of aging, a one-stop shop for all senior clinical needs. He is also leading a regional collaborative in solving mental health and addiction needs in San Bernardino County that includes all area hospitals. John has served as an experienced hospital executive for over 2 decades. Prior to arriving at San Antonio, he served as CEO at Highland Hospital in Oakland, California. John was not only in charge of operations at this 169-bed general acute care hospital, but also led the clinical and support services for the Alameda Health System. Some of his accomplishments include Alameda's accreditation as a level 1 trauma center, a baby-friendly designation, and the construction of a 9-story patient tower. John is a clinical microbiologist by training. Prior to joining the Alameda Health System, John served as Executive Director of Clinical Services, Director of Laboratory Services, and held other leadership positions at the University of California, San Francisco Medical Center. In these roles, among other things, he served as the Director of the Medical Center service lines, including its Orthopedic Institute and Heart and Vascular Institute. He also led a variety of strategic planning processes and UC system-wide operational initiatives. John earned his Bachelor's of Science degree in microbiology and immunology from the University of California, Berkeley, and a Master of Business Administration and Healthcare Management from the University of Phoenix. Dr. Kevin Parks received his Bachelor of Science degree from California State University, San Bernardino, and obtained his medical degree from the University of California, Irvine. He completed an emergency medicine residency at Loma Linda University and is board certified in emergency medicine. He has been working with Mountain View Emergency Physicians Medical Group in the emergency department at San Antonio Regional Hospital for the past 23 years. Dr. Parks has served as medical director and chairman of the Department of Emergency Medicine, as well as participating on many other hospital committees, including the Medical Executive Committee. He has been president of Mountain View Emergency Physicians Medical Group for the past 20 years and is also president of Mountain View Urgent Care Group. MVE-PMG provides emergency medical care at the San Antonio Regional Hospital Emergency Department, treating nearly 100,000 patients a year. Mountain View Urgent Care is comprised of 6 urgent care centers caring for approximately 60,000 patients per year. Prior to medical school, Dr. Parks worked as an EMT and then paramedic for 15 years in San Bernardino County. He has remained active in pre-hospital emergency medical services as medical director for Ontario Fire Department, Chino Fire Department, and Rancho Cucamonga Fire Department. He has also served on many San Bernardino County EMS committees. Currently, he is a member of the Medical Advisory Committee and the Emergency Medical Care Committee. The EMCC acts in an advisory capacity to the San Bernardino County Board of Supervisors, as well as the local EMS authority, ICEMA, on all matters related to medical services. Thank you all for being here this morning. That is quite a robust biography. We have a wealth of knowledge and influence here today. And today we're going to discuss the current and future state of healthcare in California. So we'll start with a recent report. Credit agencies such as Moody's shows that more than half of California hospitals are operating in the red routinely, year after year. What are the factors contributing to the statistics? And we'll start with George.
Well, first off, I'd like to say thank you for the invitation today. It's really my honor to be here and representing HASC and representing our hospitals across the greater Los Angeles area to have a little bit of discussion today about some of the challenges that they're facing and some of the opportunities that they have. With regard to that RAND study, there are a host of issues that are driving our hospitals into the red. Those issues include increased cost for the workforce, increased cost for technology, increased cost for pharmaceuticals. It also is driven by the fact that we have one of the lowest Medicare and Medicaid reimbursement rates in the entire country. When you combine all of that, and I know that we're going to talk about other factors that have placed some burdens on our hospitals, whether they come from Sacramento or Washington, D.C., or even at the local level. taking all of that into account, it is very difficult for many of our hospitals to balance that formula and stay above the line or in the black in the current environment. When you look at the number of Medicaid recipients in our state, it has increased year over year over year. If you take that combined with the fact that Medicaid rates have not increased to the same extent, it really is a major factor in driving over 50% of our hospitals in this state into the red.
So, John, please share some of the factors contributing to the statistics that George just spoke on.
Yeah, George covered many of them. In fact, since 2020, I believe in California, hospitals in general lost $25.3 billion in off their operating margins. And it is ever since COVID, especially, and the Great Resignation, with new bills coming through with minimum wage specific for healthcare workers now, aimed at $25 an hour, with no reimbursement increases, as George spoke to, from both federal state payers. A good bottom line now is almost just 1% margin. It's we're happy with that. Any other industry would think that's a great margin? No. So this is what we're faced with. And a host of other factors that you hear about regarding seismic regulations for hospitals, and just the cost of building new hospitals. You don't see them. And what you do see is a number of hospitals closing services. So yeah, it's a tough situation to be in right now.
What are some of the services that you've seen be closed?
I think everybody's opened up their paper and seen maternity and birthing wards closing hand over fist. We're also seeing many people closing ERs, right? We're seeing hospitals saying, hey, if we don't solve something in the next few years, we'll be closing altogether.
So, Dr. Parks, as a leader of a large physician group, how is this trend impacting healthcare providers?
Yeah, we appreciate the chance to get to be represented here today. Both these gentlemen are truly experts at kind of the higher level, and my hope is to provide some of the boots on the ground kind of perspective. So for our group, and we're not a small group, but we're not a huge group either. So this stuff affects us directly and individually. All the decreased reimbursement, the difficulty staffing emergency departments, staffing urgent cares, and the overcrowding in the emergency department that becomes this result of lack of primary care physicians, which also kind of relates to the lack of funding.
I've also heard that the state has invested billions of dollars to address homelessness. I think everybody in California is aware of the state's efforts to combat homelessness and invest in that effort. Drug addiction and behavioral health matters. Let's talk about some progress that has been made as a result of those efforts and how they are impacting those that are in need of most care. And I'll start with John and move down the line.
Okay, it's a tough question. It's tough because you're right. There's been multiple millions of dollars targeted to help with the relief for homelessness and to handle drug addiction. And I think it's a moving target. They try, but I think what we've seen to date, maybe George, you can expand on it, not a lot of success so far. Though national models are coming out, and we're trying to take the best of breed models and implement them. But you're not seeing that move the needle in Southern California yet. I mean, that's my perspective, George.
And thanks, John. I think that this is a very complex issue when you take a look at those who are experiencing homelessness, those who have drug addiction. The simple fact is that our hospitals are taking care of these patients primarily because they're presenting at our emergency departments, because we have a lack of community-based services to provide these individuals with the care that they need. Most often, an emergency department is not the place of care that a person who's experiencing homelessness needs. They show up at our emergency departments because they need a bed to sleep in, they need clothes on their back, they need a meal, and often they just want interaction. And why do they come to our emergency departments? Because our emergency departments are open 24/7, and it is our responsibility to take care of any individual who walks in those doors. The fact is, if we had more community-based services, these individuals would be able to receive care, receive food, receive clothing, receive connections to the social services that they need, in a more appropriate setting. I think that there have been a significant amount of funds that have been thrown at these issues. But from my perspective, the organizations, whether it's hospitals, whether it's community-based services, whether it's counties, whether it's cities, traditionally they've worked in silos. And I think one of the ways we can see more efficacy or better results in providing care and services and programs for these patient populations is through more collaboration. I think that's the path forward.
Same question to you. You're the boots on the ground, as George mentioned. That's one of the first touches that you encounter with people that need a warm bed to sleep in, clothes on their back, not necessarily emergency services, but basic needs for people, the homeless. What have you seen? Have any of those dollars come to your emergency department to help address those needs?
Well, we take pride in being the safety net in the emergency department. I think a lot of us who went to emergency medicine, that's part of why we do it. We don't ask questions. We don't ask about insurance. We just take care of people. The problem is that we're trying to take care of more and more and more people for a lot of reasons that we weren't initially, that wasn't on our list of things to do initially. And that includes the homeless and drug addicted and substance abuse issues. I think this past year we've seen almost 8,000 people just in our emergency department with those types of diagnoses. So there's a pass down effect. People who come in with more serious illnesses, it's harder to take care of them in a timely manner when you're taking care of so many other things. There have been some efforts to move forward help for people with substance abuse, and I'm not sure if we're going to talk about SB43 later or if that's something you want to mention now.
Right. So we will be talking about that, but please feel free to include that.
I'll just I'll just mention that sometimes efforts are made with really good intents, but without the infrastructure in place to support really good ideas, sometimes it can even make situations worse. If you get tasked with providing a certain service to a patient, but there's nowhere to send them to get that service, they just end up in the emergency department for longer. And personally, I can't think of a worse place to be if I had a psychiatric issue or if I had some other deeply emotional issue like that than an emergency department. It's chaotic and loud, and it's just probably the worst place to be. So we're looking for help to find a much more appropriate place.
Right. So earlier on, George mentioned that a lot of the leadership seem to be working in silos. What can our leaders and elected officials do to support hospitals and medical groups, George?
Well, I think that John has been a real leader in the Inland Empire in bringing parties together to talk about issues like behavioral health, like homelessness, because really when you look at those two issues, someone who is experiencing homelessness more likely than not has a behavioral health issue or has a drug addiction issue. And so you really can't talk about a patient experiencing any of homelessness, drug addiction, or behavioral health without looking at all three of those issues together. And I really think John has done an excellent job of bringing, whether it's elected officials, their related agencies, community stakeholders, and healthcare providers together in the Inland Empire to begin that collaboration that I alluded to earlier. One of the things that we are doing at the association, because the funding streams and the funding formulas for funds that are flowing from the state to counties with regard to behavioral health services, programs, and projects is set to change in the next 2 years. We are working on developing a report which ultimately will develop recommendations that we will deliver to decision makers in each of the 6 county board of supervisors and their related agencies across the greater Los Angeles area. And it is our hope, because historically, silos, people working with good intent, but the left hand, right hand, not talking to the left, it results in, we believe, wasteful spending, wasteful programs, wasteful projects. Collaboration, more dialogue is all going to be incorporated into the recommendations that we come up with. And we hope that decision makers will have open ears, open hearts, and take some of those recommendations, which we think will lead to better care for these populations.
John, George teed you up as the leader in the Inland Empire that's doing exactly that, bringing the leadership together, bringing board of supervisors together, and stakeholders that need to be a part of this. What can our leaders and elected officials do to support hospitals and medical groups?
I think be educated on the entire spectrum of homelessness and addiction medicine and who it's touching and what industries it's touching, whether it be hospitals or urgent cares like different parks. We're learning about what's happening in the counties and the behavioral health departments, but they all have to get to the table. And yeah, I'm sure Kevin Parks will mention it. And there has to be sustainability. How can we take care of these patients? Where is the best place? So today, if you have someone out on the street who's homeless, having a mental meltdown, an issue going on, where do they take them directly? It's to the ED. There's no alternate destinations. In San Bernardino County, there's no acute addiction facility to send people to. So today, it's on the backs of hospitals. So we're leading the effort. We had every hospital in San Bernardino, Riverside County, right, George, sign up and say, you know what, we're going to lead and bring behavioral health to the table, bring our Medicare and Medi-Cal payers to the table, like Optum and IHP, and try to find a solution. And in George's biography there, you had heard Communities Lifting Communities. That's actually a subsidiary of the Hospital Association of Southern California. And they're facilitating those talks with leaders like myself and Megan Ross, who's a regional leader at HASC in that area, with George's oversight.
George, please talk about HASC's part in addressing these gaps as representatives of the hospital industry in Southern California.
So we focus in on working with decision makers and key stakeholders at the local level. So think the County Board of Supervisors, think about city councils, and the agencies who can have an impact on the provision of healthcare in the communities which their constituents sit. So if there is an ordinance that's being contemplated by a County Board of Supervisors or City Council, we analyze that ordinance. We have conversations with the offices of those elected officials. We have conversations with the related agencies, think behavioral health or public health. And we talk about the impact that that ordinance might have on their constituents. If we think that it is a good ordinance, we try and convince those decision makers to take that ordinance from idea to reality, vote to approve it. If it's an ordinance that we think is either going to have a negative impact on their constituents or even get in the way of care, because again, it's already been stated, sometimes good intent does not end up with a good result. And when that happens, an ordinance that is passed that is not beneficial to hospitals or to patients or to constituents, it causes more red tape. And that gets in the way of patient care. And so it's the responsibility of the association to educate those elected officials, educate those regulatory agencies about the impact that they might have on their constituents, good, negative, or otherwise. And we represent, as John stated, approximately 180 hospitals across the greater Los Angeles area. And that is our primary focus, relationship building with those decision makers, collaborating with those decision makers, and trying to make sure that policies that are passed by, whether it's a city council, whether it's a board of supervisors, whether it's a behavioral health department or a public health department, have a positive impact on the patients, communities, and their constituents.
With that said, we're going to head out to a break. All right, everybody. Yvette Walker with ABC News and Talk, Southern California Business Report, taking a deep dive into the ever-evolving landscape of healthcare in California, highlighting prominent leaders in the industry. George Greene, President and CEO of the Hospital Association of Southern California, or HASC, John Chapman, President and CEO of San Antonio Regional Hospital, and Dr. Kevin Parks, President of Mountain View Physicians Medical Group, providing invaluable insights and updates on the current state and future trajectory of healthcare in Southern California, while exploring innovative solutions, emerging trends, and the collective efforts aimed at enhancing the health and well-being of our communities. When we return.
Hi, I'm Dana Rademacher with MGR Property Management.
A lot of people wonder about the value that property management has for their property. Property management can include all property types, including residential, commercial, and HOA. It is valuable because property managers are experienced in what can happen at your property. We're aware of liabilities. We're able to do predictive and preventative maintenance. We know what is coming up with the changes in the weather, the seasons, how old certain aspects or different capital projects at your property are. We're able to best negotiate contract pricing, legalities with your tenants, and anything else that you may need to ensure that you're getting the full value of the property. If you're interested in speaking with the representative at MGR Property Management regarding your property management needs, you can visit our website at mgrrealestate.com, or you can call our number at area code 909-581-6600 to be connected with a representative.
Ontario International Airport is on to a better way to fly with over 65 daily nonstop flights to more than 20 major destinations and the easiest airport experience in Southern California. Visit flyonto.com/Ontario to learn more about Ontario International Airport today. The University of La Verne is rated first in California for alumni satisfaction. Learn more about accelerated programs offered online and on campus in La Verne, Irvine, Ontario, Burbank, or College of the Canyons. Visit go.laverne.edu. The University of La Verne. go.laverne.edu.
Hi, I'm San Bernardino County Sheriff Shannon Dykes. If you're looking to start an exciting career in law enforcement and make a difference in your community, we are hiring dispatchers, nurses, deputies, laterals, and many more. For a complete list of our jobs and more information, visit sheriffsjobs.com.
We are the Empire Strikers, the professional sports team of the Inland Empire. We are a fast-actioned and community-inspired pro indoor soccer team. Our mission is to inspire the Empire. Home games, community events, watch parties, and youth camps are all back. Professional indoor soccer is back. Join us and come watch the greatest show on turf at Toyota Arena or on Twitch. Visit www.theempirestrikers.com for more and any information.
Cal State San Bernardino is home to the only school of entrepreneurship in California. With globally ranked degree programs, you can start your journey today to become a successful entrepreneur. Learn more and connect at entre.csusb.edu.
Welcome back, everyone. Yvette Walker with ABC News and Talk, Southern California Business Report, taking a deep dive into the ever-evolving landscape of healthcare in California, highlighting prominent leaders in the industry. George Greene, President and CEO of the Hospital Association of Southern California, or HASC, John Chapman, President and CEO of San Antonio Regional Hospital, and Dr. Kevin Parks, President of Mountain View Physicians Medical Group, providing invaluable insights and updates on the current state and future trajectory of healthcare in Southern California while exploring innovative solutions, emerging trends, and the collective efforts aimed at enhancing the health and well-being of our communities. Thank you all for being with us here today. Okay, so prior to the break, spoke a little bit about the existing challenges that healthcare is facing, both on hospitals and physicians and physicians groups. I read that already approved SB 43 was designed to address addiction and behavioral healthcare needs and get people who are suffering off the street. Emergency rooms are already overcrowded. Is this going to impact emergency rooms even more?
Short answer is yes. It will absolutely impact our emergency departments. This is a law that was developed and passed with good intent. I would say that at the end of the day, if we were allowed to transition and implement this law with enough time collaboratively, it will have a positive impact on this patient population. But our hospitals and communities need time. That is why the association has worked with several counties to implement a 2-year delay, because ultimately this was a state law that requires county implementation. And there are some counties who have only passed a 1-year delay. 1 year is simply not enough time. We don't have the resources, and if we are not allowed the appropriate amount of time, there will be more harm that is caused by cramming this implementation down providers' throats, rather than collaboratively working with providers to allow for at least a 2-year implementation time to staff up, to not retrofit, but if there are necessary changes to the workflow of your emergency departments or other areas of your hospitals or healthcare facilities, it will allow for that time so that these patients can come into the system and that the law can be implemented in the correct way.
So to you, Dr. Parks, you're the boots on the ground. You see the emergency department every day and you are already impacted. How is this going to impact already overcrowded emergency departments?
Yeah, I agree. It is going to impact us even more. And one of the reasons is there's a thing called a 5150. It's a state hold that allows us to hold somebody with a psychiatric emergency, whether they're a danger to themselves, a danger to other people, or gravely disabled. And we can keep them up to 72 hours if they aren't able to safely be discharged. In fact, we're required to send them to a psychiatric facility for evaluation for up to 72 hours. And we can't just let them go if they're on this type of hold. They can't be discharged from the ER. SB 43 adds in people with severe use disorder to the gravely disabled category. Previously, people who were under the influence or had drug addiction issues were specifically not allowed to be placed on this hold. Now they'll be included, which will greatly increase our number of patients. And as I said, we can't send these people home, so we have to keep them in the emergency department. And kind of the kicker is there is nowhere to send them at this point. There were no drug treatment facilities. It's certainly not enough for us to be able to find places to get the appropriate treatment for these people. So it's a little bit, as you said, the cart before the horse. The idea is good. We want to get people to the appropriate facilities. We want to do the right thing for them. But this going into effect immediately or with only a 1-year delay will end up with people being in the emergency department waiting for transfer to a place that doesn't exist. And as I mentioned earlier, I can't think of a worse place to have to be when you're having that kind of emergency than stuck in an emergency department.
And can I add something to that? Sure. So San Bernardino County, as an example, this is what I talk about educating local politicians. They don't know that the 2 or 3 or 4 counties who've agreed just to 1 year, their typical number of patients per ED bay in that county is about 800. So 800 patients touch that ED bay, and I'll use San Francisco as an example. You know what's here, Yvette? It's 1,800. Right? So this is where George was talking about. It's a good idea. It's supposed to help people, but they don't realize the delays that we're going to experience now in emergency rooms are actually going to hurt others.
Everyone's also talking about Prop 35, claiming it will address our most urgent healthcare priorities and protect and expand access to healthcare for 15 million Medi-Cal patients and all Californians. What do we need to know, and what exactly is this, George?
So at a high level, what Prop 35 would do if it were passed is take a tax that is levied on Medicaid managed care organizations. This is not a tax that would be levied on any citizen in the state. It would simply be levied on those Medi-Cal managed care organizations, and it would protect the funds that the state would receive as a result of these taxes, and make sure that those funds go into increasing and providing more Medicaid reimbursement for healthcare providers. That's it. Very simple. It protects the tax and makes sure that those funds go to support Medicaid rates, Medicaid reimbursement for healthcare providers.
Right. So as you said, George, this tax has been around for years. Where is the money going today? We'll start with George.
Currently, the money goes into the general fund of the state of California. And we want to make sure that those funds, once they go to the state, don't go into the general fund where they could be taken by the legislature or the governor. We want to make sure that those funds are protected so that they solely, by law, can be used to improve and make sure that we have Medicaid payments for healthcare providers.
Wow. And what do those funds look like to date, John?
Well, I think he said it correctly. It's we need it protected because where California is now, every time there's a deficit, those funds that would go to healthcare, that would help us build new psychiatric units or would help us have solutions to addiction medicine, would take the 49% of the hospitals out of the red and take care of Seismic, is being diverted, right, to close a budget deficit. We need to have those funds for what they were earmarked for. That's healthcare.
And Yvette, if I may, I think it's important for the viewership to know that there is a coalition that has been working to support Prop 35. And that coalition is made up of those Medicaid managed care plans, a variety of healthcare providers, and other key community stakeholders who see this as an important need. And your viewership can probably go on Google and just Google Prop 35 or Prop 35 Coalition, and a lot of information will come up.
Dr. Parks, how does the redirection of these funds from Prop 35 affect the emergency department's bottom line?
Yeah, the emergency department and the urgent cares, both, and the community physicians, the family practice doctors. Like I mentioned earlier, a large piece of our volume in the emergency department and urgent cares comes because there's no available access to primary care doctors. There just aren't enough. And most doctors we want to take care of the most vulnerable patients, the Medi-Cal patients, the patients on Medicaid. But the reimbursement has dropped so much over the years that we have to be reimbursed enough to at least keep the lights on and run a business. And it's, especially in urgent cares and primary care doctor offices, it's really important that funds be protected so that the reimbursement is, it just has to be enough to keep the doors open. And this will help to do that.
So we all know 2 weeks ago, Governor Newsom vetoed bills that came across his desk. One of those bills included an extension for hospitals to be seismically ready by 2035 instead of 2030. George, can you offer an overview of what this is and what this means for hospitals?
Sure. So there's a law that is on the books that requires hospitals to seismically retrofit to different standards by 2020 and then 2030. There are simply not enough funds in the system for many of our hospitals to meet those requirements by 2030. And at the end of the day, if the law were followed, those hospitals would have to close if they do not seismically retrofit. And the last thing that we need to see in this state is more hospitals closing. We have hospitals that have closed in recent years, and it has been disastrous for those communities, disastrous for those patients who now have to travel greater distances to receive the care that they need. And so we need to continue the dialogue with the administration, with the legislature, about how important it is for those hospitals to remain open. There was a lot of great dialogue that happened during this past legislature, and we're hopeful that that dialogue will continue so that we can ultimately reach some sort of agreement that will take into consideration the financial state of the hospitals that we mentioned and the need to make sure that hospitals and patients are safe if we have an earthquake.
John, please talk about how this will impact your bottom line, and can hospitals afford it? What did the cost look like?
Yeah, we can do the numbers together right now. We just mentioned that since 2020, hospitals just in California have lost $25.3 billion. They're in the red. Advocates who say, hey, let's get it done by 2030, will come back and say, hey, you've had 30 years to prepare. And what people don't understand, general public, this is why I talk about education, is this was a two-part law. The first part was to make sure hospitals can stand a major earthquake, and to do that by 2020. And for the most part, I think greater than 95% of hospitals have spent billions of dollars to do so, right, Yvette? Now we have 10 years to say not only must they stand, every part of the hospital who's taking care of patient care has to be functional even after. And, well, we've been through earthquakes. I'm from Northern California. Most have. But the numbers don't make sense. If you've lost $25.3 billion since 2020, and it's expected that over $200 billion is still needed to have these hospitals that George is referring to up and running by 2030, and with 49% in the red, and a good margin at 1%, where's the money coming from? We need help. And that's where we're looking towards our public officials to help us.
Also, Becker's Healthcare, a national publication, has named your hospital as one of the few fiscally strong hospitals with a positive outlook year after year. Will you be impacted as well?
Well, that's why I laugh about the physically positive. We're happy that we're doing so well in our community, but well is a 1% margin. I'm not going to be able to fund what our hospital has to fund, which is over $60 million still to seismically upgrade it off a 1% margin. That's 7 or 8 million with all these new costs coming down the line as well. So we're going to try our best. But what happens is, we've been talking about, let's have solutions to behavioral care and addiction medicine as an example. That money, if there was a delay, we can use that money today and open up addiction medicine centers, help recruit and train new mental health specialists. But now those are all on the back burner. And as I said, many hospitals are saying, boy, I can't even do new programs. I've got to cut current programs, or pediatrics is being cut, or maternal health is being cut. It's a very difficult situation to be in, even for hospitals who are seeing profits.
George, please talk about what will happen to the hospitals that are already operating in the red.
As a result of the seismic law.
Correct.
So those are hospitals that will have to make the difficult choices that John has described. Do we shut down services within the four walls of the facility? There are organizations that will no longer have the funding to provide community-based services. So those are services to try and get more upstream, taking a look at screenings, education, to try and get people to live a healthy lifestyle so that they don't end up in the emergency department. When you're faced with the losses that our hospitals are faced with, for all the reasons that we've enunciated today, those organizations have to make tough decisions. And those tough decisions usually mean a cessation of services. And ultimately, they can lead to a hospital closing its doors.
And so just to add into that, it's a good intent, as George has been saying, for these laws. But if the intent is to keep hospitals open, it's quite ironic it's going to close them if we don't have an extension to 2035.
Should Californians be concerned about the future of healthcare? Based on our discussion, I am. What can we do to ensure Californians receive the care they deserve? We'll start with Dr. Parks.
Well, from my point of view, I would love to see primary care funded appropriately to get better access, especially in the Inland Empire. I mean, it's a big problem. The emergency department will continue to act as a safety net, but we have to have the funds in order to remain open and remain viable. And it's the same with our urgent care centers. And I think that my view is a lot smaller than both of these gentlemen's view, in which I'm looking at just enough reimbursement to keep the centers open.
To you, George, what can we do to ensure Californians receive the care they deserve?
I think there's different ways to approach this. And your initial question is, should we be worried? You look at the three individuals in the healthcare space who are sitting at this table. I'm speaking, first of all, we are obviously all worried about the state of healthcare and the future of healthcare because of all the reasons that we shared about the challenges that healthcare providers are facing. I do always like to look for a glimmer of hope. And I do have hope for the future of healthcare for the same reasons when you look at the individuals who are sitting at this table. And beyond us, when you look at the workforce that is within the walls of our facilities and even working in the community, these are individuals, and it doesn't take that long for us to look back to the pandemic. When times were tough, the job was harder. You had people working in communities and in hospitals who, in the face of the unknown at the beginning of that pandemic, got up every day or every night, because healthcare does not close, and they showed up and they showed out and they provided care because they are mission driven. People who are in healthcare are in healthcare because their spirit tells them to be mission driven. I want to take care of patients. I want to take care of the community that I sit in. So that gives me hope that in the face of all of these challenges, healthcare will grow, healthcare will ultimately thrive. It will be in a better place if key stakeholders from the community, key decision makers from the local level all the way to the federal government will collaborate with healthcare providers. And when they come up with good ideas for improving healthcare, consult with those who are actually practicing it on a daily basis. That's how you improve healthcare. We're going to continue to face challenges with regard to funding. We're going to continue to face challenges with regard to increasing costs. But if we collaborate and if we communicate, we can end up in a better place for providers. which means we'll be in a better place for the patients and communities that we're taking care of.
John, based on what we discussed today, what can we do to ensure Californians receive the care they deserve?
Well, I'm going to close with saying ditto to George. He has it right. The only thing I would add to it is I think you've seen a thread throughout this entire program. It's just about educating. Educating not only our leaders, if we're educating the leaders, your audience today, Yvette, and that's why we love the show, is how are they going to know if our leaders don't know? That's why we're here today, to educate what's going on in healthcare, what's going on with costs. There's a dearth of providers, reimbursement issues. Here's some of the bills that do make sense, but is it the right timing? So I'm just glad we have great leaders surrounding us, like the Dr. Parks in San Bernardino County, and definitely George Greene leading the Hospital Association of Silicon Valley.
Mr. Greene, please offer a formal invitation to leaders, stakeholders, those that are making the decisions in the healthcare industry to reach out to you and be a part of that coalition with HASC.
Absolutely. You've heard a theme in what I've been saying, and that is communication and collaboration. It is our sole responsibility at the Hospital Association of Southern California to represent hospitals, the patients and communities that they serve all across the greater Los Angeles area. The way that we do that, as John has stated, is through education, collaboration, and communication. Because at the end of the day, whether it's a healthcare provider, whether it's a decision maker, whether it's someone from the community, people and community should be at the center of everything we do. So yes, Yvette, thank you. Please reach out to me and the team at the Hospital Association of Southern California. We work closely with the California Hospital Association that is front and center on all state and federal issues. We have a motto of no wrong door. So please reach out. Let's collaborate. Let's communicate. Let's work together to try and keep patients and communities in California safe.
Okay, thank you all so much for being with us today. Thank you.
Thanks, Yvette.
Don't miss my interview with Chris Carina, Rotary District Governor, 5320, originally from Detroit, Michigan, graduated from University of Michigan, Ann Arbor in 1986, and from Bolt Hall School of Law in UC Berkeley in 1990. He has been a member of the Rotary Club of Mission Viejo since 2012, where he served as the club's board from 2013 through 2020, and as club president in 2018 to 2019. He was a founding board member of the Mission Viejo Rotary Foundation, serving on its board from 2014 through 2020. Next week, we will have Dr. David Siegler, Behavioral Health Chairman of Arrowhead Regional Medical Group, who received his Doctor of Medicine degree from the David Geffen School of Medicine at the University of California, Los Angeles in 2011. He completed the UCLA San Fernando Valley Psychiatric Residency in 2015, where he also served as the Chief Resident of Inpatient Psychiatry. Dr. Siegler joined the ARMC team in 2019 as the Vice Chair of Psychiatry and soon became the Interim Chair for Psychiatry before accepting his current role in April of 2021. We will see you all next week. Don't forget to find us on Facebook, LinkedIn, YouTube, and Instagram. See you all next week.
This has been the Southern California Business Report with Yvette Walker on KMET 1490 AM, FM 98.1, and ABC News Radio affiliate, a show dedicated to highlighting successful Southern California businesses and the people behind them. Remember to visit the podcast page